e-learning for trainees. It is an initiative by the NSS Society for the benefit of postgraduates to prepare and face the practical examination with confidence and to come out successful in their post-graduation examination, final examination, both in MD and DNB. So in continuation, 1 minute. So we have the TED Talks 2. This is the second case presentation. And we have with us Dr. K. Raghavendran, Director of Anesthesia and Pain Services, Institute of Anesthesia and Pain Services at SIMS Hospitals, Chennai. Many of us in the group know him that because of his frequent share of knowledge and case discussions which he brings out time to time. Welcome to this TED Talk, sir. Thank you. And we have with us Dr. Poonima Dar. She's a senior consultant anesthesiologist at Indraprastha Apollo. And we thank Madam for joining us for the second talk and sparing her time in the PG education. Welcome, ma'am.
Thank you. And learning in the process.
Thank you, ma'am. We also have much to learn from you. The next, we have Dr. Jigisha Badeka. She will be our internal examiner. She'll be more acting as our internal examiner. She's our associate professor at PDU Medical College, Rajkot. Welcome to Tech Talks, madam. And the star of today's presentation, Dr. Payal Adya. I welcome you to TED Talks for, I want to congratulate first of all for being very brave and showing some confidence to come in front of everybody to present this case. Welcome, Payal.
Thank you, sir.
And best of luck. So I will change the slides on your behalf, okay, on the go.
Yes, sir.
With permission from the panelists, shall we start, madam? Sir?
Yes.
Please do. Yeah. So she's a postgraduate from Department of Anesthesia, PDU Medical College, Rajkot. Please go ahead, Payal.
My patient is a 65-year male Hindu patient weighing 50 kgs, is a rickshaw driver coming from lower socioeconomic class and is posted for right-sided hernia repair. The patient presented with the complaints of cough with expectoration since 3 years and dyspnea on moderate exertion since 1 year. Origin, duration and progress. Patient was relatively asymptomatic before 3 years. Then he had complaint of chronic cough on and off with expectoration, which is more during night and morning and which is aggravated by smoke. Sputum is scanty and white in color, mucoid in nature and non-foul smelling. Patient has breathlessness on moderate exertion since 1 year, which is gradual in onset but progressive in nature. First patient was having breathlessness on climbing 3 flights of stairs. Now he is being breathless on climbing 2 flights of stairs. It is relieved by taking 4-Fort MDI. It is associated with the seasonal variation. It is precipitated in cold. Last patient had attack before 6 months. Patient has no history of fever, weight loss, anorexia, chest pain, palpitation, diaphoresis, orthopnea, pedal edema, blood in sputum, hoarseness of voice or difficulty in swallowing. Past history and family history. Patient is non-case of COPD since 3 years. Patient has no history of diabetes, hypertension, tuberculosis, jaundice, MI, no any history of drug allergy, no past operative history or no history of blood transfusion. Family history is insignificant. Drug history, patient is taking tablet Darifylline TDS since 3 years and 4-Fort MDI SOS on breathless. Personal history. Patient is a chronic smoker, 1 Judy BD per day since 40 years. Diet is vegetarian, appetite is adequate, bowel bladder is unaltered and sleep is adequate. General examination. Patient is conscious, oriented to time, place, and person, averagely built and nourished. No pallor, edema, lymphadenopathy, icterus, cyanosis, clubbing, or enlarged neck veins. Temperature is patient is afebrile on touch. 74 per minute pulse with regular rate and rhythm. Normal force and tension. No radioradial or no radiofemoral delay. Blood pressure is 130 by 80 millimeter of mercury, recorded in supine position in right arm. Respiratory rate is 16 per minute and respiration type is abdominothoracic. Saturation is 95-96% on air. Systemic examination. As my patient is having symptoms pertaining to respiratory system and is a non-case of COPD, I would like to examine respiratory system first. Examination is done under proper light and exposure and in patient in sitting position. Inspection. Upper airway inspection, oral cavity including tongue, tip, tonsil, palate are normal. No congestion of pharynx. Normal nasal cavity, no deviated nasal septum. Mouth opening is MPG grade 1 and incisor gap is 3 fingers. No pursed lip breathing, no accessory muscles involvement in respiration, and respiration is abdominothoracic type with rate 16 per minute. Patient has no barrel-shaped chest, bilateral movement is equal on respiration, no undue bulging or retraction, no scars or prominent vein or chest wall. Apex bit is seen in 5th intercostal space, just medial to mid-clavicular line. On inspection of back, bilateral movements are equal on respiration, no undue swelling or retraction seen, no scar marks seen. Back and spine are normal with no kyphoscoliosis. Palpation. All inspectory findings are confirmed on palpation. Bilateral chest movement is equal in front and in back on all the 3 zones, upper, mid, and lower zone. Apex bit is palpated in the 5th intercostal space, just medial to mid-clavicular line. Trachea is centrally placed. Tactile vocal parameters equal and normal on both the sides, except in right 1st and 2nd intercostal space near the sternum, where it is increased. No palpable pleural rub or rhonchi or rales. Perfusion. Lower border of resonant knot found on 5th intercostal space in mid-clavicular line, 7th intercostal space in mid-axillary line, and 9th intercostal space in mid-scapular line. On right side, in 5th intercostal space, liver dullness is found. On left side, in 3rd and 4th intercostal space near sternum, and in 5th intercostal space just inside the mid-clavicular line, cardiac dullness is found. On left mid-axillary line, in 9th and 10th intercostal space, phrenic dullness is found. On auscultation, bilateral air entry is equal. Bilateral inspiratory and expiratory rhonchi is present. Cardiovascular auscultation is normal. Both the heart sounds are heard. And other systems examination is unremarkable. So, from history and examination, my probable diagnosis is most likely to be COPD with bronchitis, as patient is having onset of symptoms from middle life. Patient is a smoker and having cough with expectoration, dyspnea, which is progressive in nature, and tracheal length of 3.5 centimeter and positive cough test is found.
Well, shall we proceed or we want to stop here for discussion?
Yeah, just a few minutes before we go further. Okay.
Okay.
Fine. Okay, good presentation as such. Now, assuming that the patient has come to you first, before going to any specialist. Okay, see, I know, I'm sure you're going to ask opinion from pulmonologists and other things, but before that, no, say you are the doctor sitting in the PAC, patient has come to you, and you feel that, you have to assess this patient for particular type of operation. Well, you are the physician, the first contact. Okay. Now you mentioned that he is auto driver, isn't it?
Yes.
Does it have any bearing with his symptoms or the problems which he's having? The occupation?
Yes, sir. As patient is auto driver, he might be exposed to pollution very often now and then. So it can be due to the outdoor pollution also that he may have exacerbation of his symptoms or development of cough and dyspnea.
Exactly. See, he's been driving and outside, and then a lot of traffic. So smoke inhalation is real possibility. And added to that is also the smoker. I don't know about what is called Judy's PD. What is it? I can't understand that.
Actually, sir, it is like patient is coming from lower social middle class. So like it is called packs for cigarette. Like for BD, it is called as Judy.
I see. Okay. How many years doing the smoking a day?
Since 40 years.
Every day one packet.
Yes, 40 pack a year. It comes to 40 packs a year.
Oh, that's a very significant, isn't it? So I think
Yes.
damage has been going on insidiously for a very, very long time, isn't it? Now, so he has got some, but I think before jumping to the conclusion that he is COPD and all, anything else you can think of now before brand him as a COPD patient, and then why can't you just asthma? Because you mentioned that he's got a bronchi and this and that. No.
Yeah, she said he's a known case of COPD. I think that that statement I'm not very happy with. Unless you have a prescription from another doctor saying, and in the exam you will not have that. Hello.
Okay, madam.
So you can't say that he's a known case of COPD. I mean, there is a differential diagnosis to your symptom.
Common sense, as someone diagnosed him as COPD, or was there an exacerbation or admission in some other hospital with respiratory distress? Was there in such history? No.
No, sir.
Then how do you say a known case now?
So patient was taking Darifylline tablets since 3 years, and on asking him the history, he gave that one of the prescription which he had.
Okay.
Before he visited to the pulmonologist.
I see. Okay. Well, pulmonologist has already visited him. I also visited pulmonologist before. Okay. And
yes, sir.
He has made a diagnosis of, but no reference from anybody as such, isn't it? Okay. Assuming that.
Yes, sir.
That he is COPD, but any other possibilities are there apart from COPD? Someone who's coming with a, how do you say he's got a COPD based upon history, and anything else which possible which come to your mind, which can be in this patient?
Yes, sir. As patient is having chronic cough with dyspnea, he can have tuberculosis. But as I said in negative history, he has no history of weight loss or anorexia or fever. So tuberculosis can be ruled out. Then he can have acute exacerbation of upper respiratory tract infection also, but it is not associated with a fever, so infective cause can be ruled out. And patient can also have left ventricular failure presenting with cough and dyspnea, but as patient doesn't have history of orthopnea or paroxysmal nocturnal dyspnea and no history of pedal edema, so cardiac cause can be ruled out, and mostly patient is having history of smoking, which points towards COPD more likely.
I see. Anything else? Any other possibility? Apart from cardiac problem you mentioned about any asthma problem is there? Asthma? Can it be just asthma?
Yes, sir.
Exacerbated by, see, there are different types of respiratory problems. Patient can have a chronic bronchitis, can have asthma, he can have emphysema. Now, which one you think he fits into the thing? Because you mentioned about clinical examination, mentioned about a lot of V's and bronchi and all, isn't it? So, what do you think? Is it bronchitis with V's, or what exactly he's got?
The patient is having cough and dyspnea both, and dyspnea is progressive in nature. So my most probable diagnosis will be chronic bronchitis and not asthma. And as patient doesn't have any history of allergy or family history, and it is onset from the middle life, so asthma can also be ruled out.
Yeah, that's what. See, the age is important, isn't it? See, someone who has been having since very early age, you think more in favor of asthma, whereas a smoking-related history and an occupational suggestive of that, you think more about chronic bronchitis and other things now. Okay, emphysema again altogether is a pathological diagnosis actually, and then so these are things you have to keep in mind when you sort of approach a patient and then diagnose also. Okay, now how will you grade is dyspnea? He said that what did he say exactly when he said about dyspnea? I mean, did you quantify or put him in a particular grade or something like that?
Yes, sir. Dyspnea most commonly respiratory dyspnea, can be graded according to the Modified Medical Research Council grades, that is 0, 1, 2, 3, and 4. 0 is patient is breathless on strenuous exercise.
Okay.
Then 1 is patient is breathless on hurrying up on level ground or climbing 2 to 3 flights of stairs. Then 1 is patient can't walk at the same pace at the persons of the same age, other persons of the same age. Patient has to take rest in between while walking at the normal pace. Then 3 is patient can walk only up to 100 meters and has to stop and take breaths. And 4 is patient is unable to dress or undress himself and is even breathless at rest.
Okay, so that is a extreme. See, okay, this is from the gradations which he, from the whatever symptoms she described, you can have a fairly good idea about his disability as such. Okay, now you have sort of know that he has got respiratory distress. Was there any patient in the past on and off? You said that he went to some doctor before and they prescribed some medicines. Was he hospitalized? But was he put on any oxygen that time? Was he given antibiotic at the time?
He had a history of attack before 6 months, but he was not hospitalized. Neither he had requirement of oxygen. He was given antibiotics and he was cured by that time by the antibiotics itself.
Does it have any bearing on the gradation as such? The previous exacerbations, admissions, not?
Yes, sir. It is grade A, B, C, and D. If patient falls, sorry, sir.
Which is according to which classification is this grade? A, B, and C, and D.
It is a staged classification of COPD.
No. As per a particular name is there for that. See, you said about one grading for this name mentioned. What about this grade? A, B, C, D. Any particular grade is there? No idea. Okay, good. I think gradations are a lot of books available actually. The one which is very popular is the one called as gold. No, that is the
yes, a gold classification.
Can you give a full expansion of that gold classification?
Ayal, are you connected?
Hello, can you hear?
Yes, sir. We could hear. I think
it is a global initiative on the assessment on chronic obstructive lung disease. Okay, that's called gold classification. Okay, so there only you have the A, B, and C. Then you have what's called the CAT. CAT is the what is CAT?
Yes, sir.
There's another assessment. It's called that's a COPD assessment test. Actually, there's one. Then you have what's called NICE guidelines. What is NICE guidelines? National Institute of Clinical Excellence. Okay, there are some more guidelines, but you just have one guideline which you must know, and that should guide you actually. And then you can put in particular, because see these exacerbations, and then the patients what is his level of this thing working, and what all things he has on. All this depends upon the classification also. Okay. So just you have to have an idea about the classifications, and then you have to prepare these patients as per the gradation as such. Okay. So you say that A, B, and C, and D. Okay. So which grade will you put this patient if you have to assess this patient? Is sitting in the PAC. Where will you put him?
Sir, as patient is having MMRC grade 1 and patient is having no history of hospitalization in past 1 year, I would like to put it in stage A. And according to the gold classification, it is based on spirometry.
Yes, exactly. So gold is based upon spirometry. Okay, you have to, yeah. So that will come the next question. I think we'll get actually. So gold will depend upon classification based upon the spirometry. See, that is a thing which we have to know. Okay. See, dyspnea is different. Okay, what is his level of tolerance? How much he can work and how much he can climb up? All the things now. Okay, so this is actually a spirometry classification. Okay, plus and then also based upon this only, the treatment also will start. Okay, now you mentioned about was the investigations done for him? No, not done. No. You have put order, is it not? No. Suppose before ordering for the investigations, okay, I'm just asking only simple things only. See, you are sitting in the PSC, okay, and just want to have a rough idea about his level of his involvement, how much is how much affected the COPD and all, and whether he a rough idea about how he's going to tolerate anesthesia and all, okay, and also choose the techniques. Is there any way you can simply assess his respiratory status? Just looking at him, appearance, and by doing some simple tests?
Yes, sir. By respiratory rate, breath holding time, type of the respiration.
Okay. No, go one by one. See, you have to ask him certain things like, see, how much flight of stairs he climbed. Was in lift? He came by lift or he came by walking? Was he breathless at rest? What is the level of, what is respiratory rate? Okay, these are all things, clinical simple assessments, okay? Then when he sits, how much time it takes to get his breath back, and then when he's talking, is he comfortably breathing, talking, or he has to pause and take some time? These are simple things which will give you some idea, okay? Then breath holding is very simple things. So how do you exactly, how exactly do that, breath holding? You do it or no? Do you do it in a
Yes.
PSC? Okay?
Yes, sir. Yes.
If you do it, then how do you do it? Yes.
First of all, sir, taking history of the patient, I will start with the history of the patient. Then I will examine the patient. Then I will look for the respiration, like bedside PFT, like respiratory rate, breath holding time. Then match blowing test, post expiratory time. I would like to see.
You say about bedside test, or you can say when you are seeing him in the PAC itself, pre-op checkup itself, using some simple measures, simple things, nothing very complicated. PFT will do. We will send him to the PFT lab, and then there got all the gadgets are there. But before that, you want an idea. And suppose you're working in a small hospital where you don't have access to all this PFT, you got not a pulmonologist, then still you have to make an assessment. Then how will you go about it? That's what I want to know.
Sir, I will do bedside test. First of all, I will look for respiratory rate. Normal is 14 to 16 per minute. So this patient has normal respiratory rate. Then I would like to assess breath holding time of the patient. Normal breath holding time is greater than 25 seconds, and breath holding time indicates the cardiopulmonary reserve of the patient. If it is about 25 seconds, then it is patient has normal cardiopulmonary reserve. If it is between 15 to 25 seconds, then patient has moderate cardiopulmonary reserve. If it is less than 15 seconds, then poor cardiopulmonary reserve. And if at all patient is having breath holding time less than 10 seconds, then it is contraindication for the elective surgery. Then I would like.
No, breath holding. You will ask him to take a deep breath and hold breath, or just normal breath and hold breath?
I will ask the patient first to take the deep breath and then expire, and then I will ask the patient to take deep breath and hold it for the maximum time he can hold.
Yeah, that's a normal breath. Not too deep breath and hold like that. Okay, that will be give false. What by any other test you can think? What is the name of the test called? Breath holding time test.
Sabra says breath holding time.
Okay, next, anything else?
Then I would like to see 6-minute walk test. If patient can walk 400 to 700 meters in 6 minutes, then it is considered as normal. And 6-minute walk test indicates the vital capacity of the patient. If it is less than 400, then it is abnormal.
Okay. Anything else?
Then I would like to go for the forced expiratory time. I would ask the patient to take a deep breath and expire, and I would like to keep my stethoscope over the trachea so that I can hear the expiration. If it is more than 6 seconds, then it is highly suggestive of chronic obstructive pulmonary disease.
Okay. Anything else?
Then I would like to see for the match blowing test. I would ask the patient to blow a match in the room where there is no air movement, and match is kept at the same level as the mouth and at a distance of 6 inches, and patient is to blow the match with the mouth wide open without pursed lipping. If patient can blow the match from 6 inches distance, then it indicates that the maximum breathing capacity. is 60 liters per minute.
Okay. And vital capacity more than?
Vital capacity more than 1.5 ml per kg.
5 liters. Okay, yeah. It's not. No, that's okay. This will give a rough idea. You can always quantify. You can always confirm it as spirometry. But then sitting in the OPD itself, you can simple test will give you certain idea about. Okay, it's not okay. Anything else? You can bedside.
Cough test. Cough test. I will ask the patient to take a deep breath and cough. If it leads to the recurrent coughing, then it is indicative of the chronic bronchitis. Then wheeze test, asking the patient to take deep breath and auscultating between the scapula. If the wheeze is present, then it is likely to be chronic obstructive pulmonary disease. And the tracheal length of less than 4 centimeter is indicative of the chronic obstructive pulmonary disease. Asking the patient to inspire and expire, measuring the tracheal length at end inspiratory position and end expiratory position. Usually there is a change of 2 centimeter and end expiratory position, tracheal length measured from the above the thyroid cartilage to the suprasternal notch. Usually it is more than 4 centimeter. If it is less than 4 centimeter, then it is suggestive of COPD.
Okay. And any simple instruments you have at bedside which you can use? Any other thing?
Yes, De Bono's whistle.
Okay.
We can use for measuring the peak expiratory flow rate, and right peak flow meter can also be used for measuring peak expiratory flow rate.
Very small equipment. I think we used to have it in our clinic when we were students those days. Now I'm not sure that anybody is using it now. So you can have a very good idea about these tidal volumes and even minute volume, and even you can have a ask him to breathe in and out for quite some time. Then you can have an idea also. And also from there also, and then there are some miniaturized equipment available nowadays, which will even give you an idea about vital capacity also, but they are more sophisticated. But then simple tests will always give an idea, and then also give some amount, give you an idea about how much the patient is really affected and whether the patient is going to need further management or optimization before they can take for any operation before. Because see, the pre-op checkup is very important because you are the one who is going to clear the patient. Okay, and actually, if a patient is well optimized, then he's not going to give much of a problem. Whereas if not properly optimized, he is going to give a problem at every stage: pre-op, during operation, and post-op. So, assessment is very important. And the next thing will be, how do you ask investigation? What are investigation asked for? And how do you prepare the patient? I'll ask Dr. Purnima to take over now.
So, Payal, when you were taking the history, you said the patient was on Foracort inhaler.
Yes, sir. Yes, ma'am.
What is Foracort? Don't use brand names. Preferably talk about the generic drug in that. So what is Foracort? Is it important or is it not?
Yes, madam, it is important.
Why is it important?
Because Foracort contains formoterol and budesonide. Formoterol is a long-acting beta agonist, and budesonide is a steroid. So we need to know on what medications patient is and how he improves.
Right. And did you ask him whether he was taking anything else intermittently besides the long-acting beta agonist? Was he also prescribed some short-acting ones to be taken in between? And was he taking anything also? Is that also important?
Yes, madam, it is also important, so that we can come to know how many exacerbations patient have.
Yeah, and how well controlled is he on these medication that he is taking, right? So that's one. When you talk about medication, talk about the components. Don't say Foracort, say the individual components of it. Okay, so the examiner knows that you know that the patient is on inhaled steroids and on inhaled beta agonists and long-acting one at that. Okay?
Yes, ma'am.
The second thing you said was the patient was having bronchi when you saw him. What does that indicate?
Ronchi, madam, indicates that the patient has narrowing of the airway, and because of the narrowing, there is an obstruction to expiratory and inspiratory flow. And because of that obstruction, it gives the foreign sound or ronchi.
Which also indicates that he is not, extremely well controlled on whatever medication he was on, right? That he
Yes,
probably requires something extra. That he is not ready to go into the theater straight away. Yes?
Yes, ma'am.
Okay. So, so now you've examined him, you have done the bedside PFTs and everything. Why did you do all that? Why did you go to the extent of checking his, peak expiratory flow rate, making an estimation of his forced expiratory volume, his forced vital capacity, all these bedside tests? Why did you do that?
Because, madam, when we are going to anesthetize a patient, there will be the change in the lung physiology, and there can be change in the functional residual capacity, vital capacity of the patient. So, first of all, we need to know the baseline capacity, lung capacity of the patient. So,
Yeah,
I examined.
so you want to know how this patient will behave, isn't it?
Yes, ma'am.
Under anesthesia. So, what are your concerns? What are your concerns? What can happen? I mean, only if you know what can happen will you look for it, and will you be aware that this can go, this is what can go wrong, and you will prepare yourself for managing that case intra, right? So what all can go wrong?
A patient can have intraoperative acute exacerbation of the disease. Patient can have bronchoconstriction or spasm. Then he can have
intraoperative bronchospasm, isn't it? So that's one he can have. What else?
Patient can have hypoxia.
Right. Because of?
Hypoxia can be because of bronchospasm or acute exacerbation of the attack also.
Acute exacerbation of the attack means bronchospasm only, no? What else will happen?
Yes.
Anything else can happen?
Atelectasis.
Atelectasis. What else? Anything else? Intraoperatively, those will be your main concerns, that he should not have bronchospasm and he should not have hypoxemia, right? What else can happen intraoperatively if this patient were to go? Let's not consider that he is for a hernia surgery. Let's treat it as a general COPD patient who is coming for surgery. What else can happen? You said hypoxia can happen because of bronchospasm and atelectasis. What else can happen in a patient of COPD?
Intraoperatively, patient can develop tension pneumothorax.
Why?
Because of the mechanical ventilation and IPPV mode of ventilation, or due to rupture of bulla, if we give high PIP, then there can be tension pneumothorax.
Right. What else? What else can happen? Is a case of COPD. What is the pathology? What do you, when you're grading a patient, there's something that you look for in a patient that makes you think that, you know, he's a high risk patient. What makes you think that a patient of COPD is high risk for surgery? What is the main indicator that tells you, no, this patient may give you trouble in the post-op, may require post-operative ventilation, or may take time to come off the ventilator?
If the patient has associated right ventricular failure or patient has developed core pulmonal, then it is indicated the high risk.
Yeah. Before that, you know, a raised carbon dioxide, a raised PaCO2, isn't it?
Yes, madam.
So clinically also, of course, that will come in your investigations if you do the ABG, but clinically clinically, can you make out a patient who may be having CO2 retention? What are the signs of CO2 retention? In other words, I'm asking you, what are the signs of CO2 retention that you will look for in a patient of COPD in the preoperative period?
Madam, usually when patient of COPD is having CO2 retention, patient will have his level of CO2, higher level of CO2, patient will be adjusted and he might be asymptomatic. But if there is CO2 retention, then patients may have low saturation, then patient may have altered mental status, or may be confused, or patient may be hypoventilated, or there maybe patient might present with a complaint of even headache, nausea and vomiting also.
Right. So though that is, something, if they are in severe COPD exacerbation, patient comes to you with in respiratory failure nearly. But otherwise, simple things like sleep disturbance in a patient, warm hands, clubbing, like the typical blue bloater kind of signs on examination, they can give you an indication that this patient may be a CO2 retainer. So disturbed sleep is also one of the, when you take the history, of course you said that he doesn't have any change in all that. So then this was during, so carbon dioxide, so hypoxia and then hypercapnia is the other thing that you would be worried about when we were talking about what are the problems that you may face, isn't it?
Yes.
And post-operatively?
Post-operatively,
the other main thing that will bother you is his post-op.
Post-operatively, patient can have hypoxia, atelectasis, pneumonia, acute exacerbation of the attack. Patient may develop post-operative
respiratory failure.
Respiratory failure, yes, ma'am.
Right. So yes. He may may get pneumonia, increased chances of pulmonary complications in these patients. So what are the factors which are responsible for increased incidence of post-operative pulmonary complications in a patient with COPD who is coming for, say, abdominal surgery?
Madam, post-operative predictors of the post-operative complication we can judge by the ARISCAT criteria. So when the ARISCAT score is less than 26, there is low risk of post-operative complication. If it is between 26 to 44, there is moderate risk of post-operative complication. And if it is greater than 44, then there is high risk of post-operative complication. And it is based on the 7 factors, that is age, preoperative SpO2 of the patient, preoperative hemoglobin of the patient, type of the surgery or surgical incision, then duration of surgery, then whether patient is having emergency surgery or elective surgery, and on the respiratory infection in last 1 month.
Right. So that is why it is also important when you take the history, you have to check if the patient has been on any antibiotics. So many of these COPD patients may be on long-term antibiotics, especially erythromycin or one of those azithromycin type of medication. So it's important to note that history. So this patient, so you may get an indication that this patient may be one of those, harboring some degree of infection. Okay. So what are the other things that will affect the chances of a good recovery or post-operative pulmonary complications in a patient with abdominal who is undergoing an abdominal surgery? What else contributes to it? What you said the site of surgery. So how does the site of surgery contribute to the post-operative pulmonary complications?
Madam, if it is more towards
right.
So there will be splinting of the muscles of respiration, and it will postoperative analgesia is also the main thing which we need to provide to the patient.
So, post-operative, so the upper abdominal incision will cause a higher incidence of post-operative pulmonary complications because of more pain and inability to clear the secretions, right?
Yes, madam.
Okay. You said about all that, and Dr. Raghavendran, you want to ask her something? While
Yeah,
I'll
can
just
you go back
collect
to the
my
investigation
thoughts.
which is done for this patient?
Okay. Okay.
Okay. Now, what are the abnormalities expected in, say, leave alone this patient, in a COPD patient, what do you expect the hemoglobin to be? Is it normal or high or low? What will be it?
Sir, COPD patient can have polycythemia and raised hemoglobin and raised hematocrit also.
Okay, right. What about total count? Does it give any indication of
If patient has
population?
if patient has acute infection or acute exacerbation, then total count can be raised.
Yeah, it indicates the patient is having some sort of a respiratory, some infection lurking, so which needs to be treated actually. Okay, so and see, these are all the general tests you have, which you ask every patient now, and then presence of diabetes and kidney problems and other things are always important. Okay, so but specifically, you mentioned about the auscultation revealed wrong pain also. So you feel that he's okay to go for operation, or you look like do something to improve his condition. Before that, what are the investigations which you asked for specifically to assess his respiratory system?
Sir, I would like to ask for spirometry if it is possible.
Okay.
And I would like to optimize the patient first by continuing the bronchodilator drug which he is taking.
Okay, you mentioned about bronchodilator. You mentioned about what is it? Theophylline. Is it aminophylline something? No, and other one is steroids. Steroid. Do you think that these are the ideal drugs which a patient should be having to optimize a patient with COPD, or is there any different criteria, different suggested methods available now? Because probably he's not able to afford all this. Hello, can you hear? Hello?
Yes, sir. Yes, sir. We could hear you, sir.
Yes. Yeah.
Okay. Right. So I think he's on a theophylline tablet, aminophylline tablet, and also on steroids actually. So I think the guidelines are much different nowadays. I'm sure that he has had a proper treatment. Probably he's taking medications on his own. Okay. Now, based upon this gold whatever classification, how will you go about it? No, I'm sure that pulmonary is not going to agree if he's going to prescribe for this patient. That's why you can find that patient is lying wheezing. Okay.
Yes.
So what are which you feel they should be having this patient? See, wheezing, right? And he's on Foracort now and then he's taking a puff, isn't it? And he's on aminophylline or a etophylline tablet, isn't it? Hello?
Yes, sir.
Can you hear now?
Yes.
Yes, sir. We could.
Anything wrong?
Oh,
Hello?
we can hear you.
Okay, yeah. Okay, go ahead with the thing. Come. Can you hear now?
Yes.
We can hear you.
Yes, sir.
Okay,
Yes,
fine.
I can hear you.
Okay, tell me that as per the class gold type, A, whatever, see, based on spirometry, what are things you should have? Have you heard about this short-acting beta agonists and long-acting beta agonists, and then muscarinic antagonists, all these things you have heard about?
Yes, sir.
Are you not the ones to be preferred nowadays in place of steroids straight away?
Sir, I would like to prefer short-acting beta agonist along with the short-acting anti-muscarinic agents, inhaled, like salbutamol and ipratropium.
If it is a chronic one, if it is acute one, you prefer short-acting. But if it is a chronic one, you would like to go for long-acting, isn't it?
Yes, sir.
Okay. So I think that's why you have to go about it, isn't it? And then you go for the steroids only when you feel that there is some inflammatory component in that, And also when there is there any differential count made in this investigation? Do you see?
Sorry, sir.
What is the differential count here? Total count, differential count.
Yes, sir.
Was there any, what about the eosinophil count in this patient?
No, sir, no alteration in the differential count. It was normal. Total count and differential count was normal.
Normal. No, but does the eosinophil count, does it indicate something?
Yes, sir, differential count, when it is neutrophil is raised, it is spatial indicative of the bacterial infection.
Fine. If the eosinophil count is increased, what does it indicate?
If eosinophil counts are raised, then it indicates allergic attack or exposure to some allergen.
That is a situation when you have to go for the steroids, that is ICS, inhaled corticosteroids. Okay, that comes in the probably along with the short acting or long acting and long acting beta agonists and long acting muscarinic antagonists. Then only comes this one. If the eosinophil count is more. Okay, all right. So I think that's how you go about it. Is there any other? Okay, now coming to the spirometry, what do you expect to see in this patient?
So spirometry, according to the goal classification, I would categorize the patient in all the stages. FEV1 will be less than 70%. FEV1 to FVC ratio will be less than 0.7. And if it is stage 1, then FEV1 will be greater than 80%. If it is stage 2, then FEV1 will be between 50 to 80%. If it is stage 3, then FEV1 will be between 30 to 50%. And if it is stage 4, then patient will be having FEV1 less than 30%. Or if FEV1 is greater than 50% with the PaO2 less than 55 mmHg and PaCO2 greater than 50 mmHg.
Yeah, that's what. See, good. See, we have to know the FVC and the FEV1. Okay, the relation is very important. Okay, and then that will give you an idea about where to put the patient, which classification you can put the patient. Okay, so and then also it will give you an idea about how the patient is going to withstand your anesthesia and your surgery post-op, how you're going to behave post-op also. Okay, so now then you have to take some measures to improve his condition. He's come with a wheezing. Okay, when you see him, auscultate the lung, is wheezing. Okay, now you're going to after this is spirometry, you're going to before and after bronchodilation, isn't it?
Yes, sir.
How will you do after bronchodilation? How will you do it?
Sir, after giving bronchodilator, I will advise spirometry after 15 to 30 minutes of bronchodilator. And if there is improvement of more than 15%, then it is suggestive of more likely to be asthma. If it is the improvement is less than 15%, then it is suggestive of COPD. And in most of the COPD patients, the spirometric improvement after bronchodilator is less than 15%.
No, actually, you are supposed to ask him to stop all the bronchodilators beforehand. See, short acting, stop 6 hours before, long acting 12 hours before, and if he's on a very extended acting thing like theophylline or 1 day before. Okay, ask him to stop all these things, and then minutes short acting, he can put long acting, and again combined. If it's combined bronchitis, 40 minutes later you have to take one more reading. Okay, then you have to look for an improvement. So if the improvement is there, then you can sort of take it that it has to be further optimized. Not okay. Suppose not much improvement, then you have to escalate that the water bronchodilators and whatever he needs actually. Okay, so combinations and all this there. Okay, now when you see then the next thing you have to see is flow volume loops. Okay. Now, what do you expect? He said he's got a wheezing. How does the flow volume looks like in a patient with who's got a more of an obstructive element?
Sir, patient will be having the expiratory curve to be dog-like shaped because the patient will be having obstruction while expiration. So there will be the dog-like shape appearance of the expiratory loop in COPD patients. And there are
there can be different types, restrictive, obstructive. But when a patient having a wheezing and then he's got some dyspnea and doing some work and all, the expiration is affected definitely, isn't it? And then your bedside also you have found that this forced expiratory time is more than about say 3.5 seconds now. So the expiratory part only will be affected, isn't it?
Yes, sir.
There will be reduced curve and then some sort of a flattening will be there. Okay. So, and then you have to have an idea about what is called as say FE, forced expiratory flow, isn't it? FEF 25 to 70%, how it looks like. Okay, is it effort dependent or effort independent?
FEF 25 to 75% is, sir, effort independent.
Independent. It is for small airways, right? Initial
Small airways.
point is effort dependent. Okay, so that's how you have to know, and then you can quantify and then see how we can improve and optimize and then prepare him for the operation. Okay, surgery. Any other tests other than spirometry?
So I would even like to see for the serum protein level, which may be reduced in the patients of COPD because of the excessive.
What all blood tests will you do besides CBC? You said CBC, complete blood count. Besides that, what all blood tests will you do? You said now, what all blood tests? Will you do anything else?
Yes, madam. I would like to even look for random blood sugar and serum creatinine and blood urea nitrogen level and serum protein levels, serum albumin specifically.
Anything else? Why albumin?
Because, madam, as the patient is having COPD and sputum cough with expectoration, there will be loss of the proteins along with the cough. So there can be lower albumin levels. And ABG, patient is posted for the major surgery.
Right. And what about liver function tests? Is there any indication for doing liver function tests in these patients?
Yes, madam. LFT should also be done because of the smoking, there will be effect on the hepatic enzymes. So we should even look for LFTs.
What else? What are the besides the blood tests? You said ABG and what else? We'll discuss about the ABG a little later. Just finish off all the other tests. What else would you do in your preoperative?
ECG and chest X-ray.
Yeah.
Right.
Besides,
what do you expect to see in the ECG? What will you look for?
Madam, I would like to look for the right axis deviation or presence of the picked P wave, P pulmonal, or presence of the right ventricular hypertrophy from the ECG.
Anything else that these patients are prone to, especially if they are, like borderline hypoxic, hypercapnic? They often have supraventricular arrhythmias, so you should look for any arrhythmias in these patients. I mean, obviously, if you see the ECG, you'll be able to see it, but that is one of the findings, and that would warn you of problems. So, you said about serum electrolytes you would do. Why would you want to do in the KFT serum electrolytes in these patients? What will you look for particularly?
I would like to look for the madam sodium, potassium, and the chloride level as well.
Okay.
Because patient can have respiratory acidosis associated with the hyperchloremic metabolic acidosis or metabolic alkalosis.
What? Hyperchloremic acidosis.
Yes, ma'am.
Why would he have hyperchloremic acidosis?
Three traces mainly. No?
Okay. What about electrolytes? You said you would do potassium, but something you would look for, potassium. Will it bother you to know the potassium levels in these patients? These patients may often be on diuretics, so hypokalemia may be common, and also there are two reasons for hypokalemia in these patients. What are they?
Beta agonists and potassium, what happens?
Diuretics will lead to the hypokalemia, and beta agonist can lead to the hyperkalemia.
Beta agonists will cause what? What happens to potassium with beta agonists? It will cause hypokalemia. They cause the movement of potassium into the cells. So you will have extracellular or hypokalemia. Okay. So, and which makes them more prone to arrhythmias and makes the arrhythmias worse. So you must look for serum potassium in these patients. That's important. And also they are on steroids. That these sometimes if they are on oral steroids, the steroids itself, they can also cause fall in potassium levels. Okay, Payal?
Yes, ma'am.
What were the X-ray chest? You saw something, no?
Yeah. So what would be the findings in the chest X-ray?
Chest X-ray, madam, there can be prominent bronchovascular marking, more horizontal ribs placement, then tubular-shaped heart. There can be flattening of the diaphragm and hyperinflated lung folds.
What about, you will look only AP, or what about lateral?
Sir, I would look for both AP view as well as lateral, because if it is an emphysema.
Yeah, exactly. So you have to know, now if you hyperinflated lung, hyperlucid lungs, tubular heart, flattened diaphragm, and then a lateral film, what will you see?
Sir, AP diameter from lateral I can find out.
Okay. Anything else? What about retrosternal gas? So the lot of air.
So the lung goes between the heart and the sternum, because the lung is hyperinflated. So you see some air between on the lateral view, you see some air between the heart and the sternum. Okay, Payal?
Yes, ma'am.
Before you, I think, go next part, anything else, one special test which is available nowadays, okay, which is done in many centers in the world, Western world actually. They do it for assessing in a more quantitative manner. What is that actually? Can you tell me about that? You heard about this CET, cardiopulmonary exercise testing?
Yes, sir.
What exactly is that?
So cardiopulmonary exercise testing, usually it is done for knowing the cardiac test along with the treadmill test and the head crunch or hand grip exercise test.
No, it's more like it's a lab test where your patient sits and a bicycle ergometer, and then test takes about nearly 40 minutes time, but actually you'll be doing only for about 10-12 minutes only. Okay, probably different some other tests. It actually, it's where your patient is hooked to various devices and then they measure a lot of parameters. I think probably you can look into the literature about it, CPET. It is done in, especially, when you are thinking about subjecting a patient with COPD to a major abdominal operation, laparotomies or a heart operation or a major aneurysm repair or even transplant surgeries. They have to know how much reserve the patient has got. Okay, so that will give they derive a lot of plots. Okay, a lot of information, and they put what's called 9-panel plot. Okay, so there are some panels which are indicative of lung function, some for cardiac, some indicate both lung and cardiac functions. Okay, and then they will give exactly how the patient can withstand anesthesia, surgery, and post-op recovery and all. Okay, very sophisticated test. It's not very complicated. And then they derive parameters like oxygen consumption, carbon dioxide, how much is produced, and then the volume expired. And then they have other things like anaerobic thresholds, oxygen pulse, and so many things are there. They also do an ECG, and then they also do the SpO2, all these things now. Okay, so specialized test actually. No, I'm just saying for the completion. Okay, we not do it for a patient coming, for minor operations like hernia repair or something like umbilical hernia, etc. But certainly you have to keep these tests in mind when you are planning to subjecting a patient to a major procedure like major laparotomies, aneurysm repairs and all. Okay, sometimes it may even guide you instead of going for open repair aneurysm, go for endoscopic repair. So it will guide you because based upon the cardiorespiratory result, it indicates whenever a patient who has got a lung problem will always develop later cardiac problem also, like call pulmonale and pulmonary hypertensions and other things will happen. Okay, so that's what I think we have to keep it in mind whenever you investigate and evaluate a patient for an operation. Okay.
One, going back to the chest X-ray, Payal,
Yes, ma'am.
every patient of COPD have a X-ray like that, like Surendra has put up?
No, madam. Most likely, the chronic bronchitis patients does not have the X-ray findings, prominent X-ray findings.
Right. And what about the typical COPD patient, severe COPD patient? What will you see in that patient? This is the picture that you
We will
get
be seeing
emphysema. You may see a
emphysema is
dilated
bulla,
heart,
madam.
actually, isn't it? In very severe COPD
Yes.
cases with cor pulmonale, you may see a dilated heart as well, right?
Yes.
No, you're not convinced.
Yes, madam.
Okay.
Convinced.
Okay. So if somebody asks you X-ray findings in COPD, then X-ray findings in emphysematous patient will be different from the COPD. You know, like there are two classes, the two types of patients of COPD. So the emphysema will be like this. Patients with COPD with the blue bloater kind of thing with cor pulmonale will have a different chest X-ray picture. So what are the findings in, when will you do a blood gas? What is the indication? Will you do it in every patient? Will you do it in this patient who is presented to you for hernia surgery?
Sorry, madam, I was disconnected in between, so I couldn't understand the question.
No, I said, will you do a arterial blood gas in this particular patient who has come to you for a hernia surgery? Is it indicated?
No, madam.
So, when will you do blood gas? What are the indications of ABG?
When madam, patient has a history of hypoxemia or patient has history of
Payal, how do you know history of hypoxemia? How, patient बहुत थोड़ी बोलेगा तुमको my oxygen level is down. No.
If patient has hypoxemia.
So don't say when the patient has history of hypoxemia. So say when the patient has moderate to severe disease, है
Yes.
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 So, because patient is not going to tell you that I have hypoxemia, right?
Yes.
So patients with moderate to severe disease, by your various classifications, the ones who are fitting into class 3 and class 4, what else?
And if patient is posted, if patient is posted for the major surgery, then I would obviously like to see the baseline PO2 and PaCO2 level.
Okay, and typically you would like to see if you can do a pulse oximetry in the OPD or in your PSC clinic. Then anybody with a pulse with a saturation of less than 95%, you would do an ABG, even if it's for a minor surgery. Okay. Okay.
Is ABG, can you interpret is ABG? What, Payal? What's the finding here?
Yes, sir. It is in respiratory acidosis.
Okay. Is it compensated or not compensated?
It is compensated respiratory acidosis, sir.
Okay. Almost compensated, can you say? Okay. Yeah. Lower limit of it's 7.36 to 7.44 is a pH, but 7.34 PCO2 is 72 is definitely high. Respiratory acidosis, but then there's compensation comes from where?
Bicarb levels, sir. It is 34.
34 definitely is high because bicarbonate is retained by the kidney, so it's definitely it is a chronic problem because kidneys take some time to compensate. So definitely it is there. Now this PCO2, does it have any bearing on the oxygen tension? Does it cause any problem? Suppose PCO2 is say 72, will it have any effect on the alveolar oxygen tension? Down to basics, okay, before we go any further, because sometimes this is a question asked actually. Young-House modification Bohr equation. What's it actually?
No, sir.
PaO2 is equal to PaCO2 upon R, no? PaO2 is equal to PaO2, that is alveolar oxygen tension is equal to PaO2, that is inspired oxygen tension minus PaCO2 upon R, okay? So whenever the PaCO2 goes up, the oxygen tension in the alveoli will come down, definitely. So PaCO2 is going about 60, it will have, it's going to reduce oxygen tension in the alveoli, definitely, unless you supplement oxygen with extraneous oxygen, okay? Oxygen therapy. Okay, these are things we sometimes we get into, and then you're going to be asked these questions now. Okay, so definitely CO2 will have an idea. Not only it causes as well, it also decreases the oxygen available unless you give some oxygen. Okay, and if you give oxygen, sometimes they can even go up now, is it not? Because hypoxia also may go up, so they also go up. So all these things influence, you must have an idea. Okay, so anything else?
What is so? What will be your cutoff CO2 for accepting? Before you say that the patient is a very high risk patient. So out of the PaO2 and PaCO2, which one is more important in to determine the prognosis?
PCO2 is more important for determining the prognosis, madam.
Yes. So what is the cutoff? You know, what will make you worry? PCO2 level of what?
PCO2 level.
Coming for a major abdominal surgery.
PCO2.
Yes. What level of PCO2 will worry you?
Cutoff.
Greater than 55 mm, madam.
55 is too high, ma'am. So anything more than 45 is means it is not within normal limits, and you need to take care of this, because definitely the patient is going to hypoventilate a little bit in the post-operative period. So it will go into 50s and it will go into respiratory acidosis. So 45 more thoroughly, and try and prepare further before you take up for surgery. Okay.
What about the PO2? Are you worried about the PO2 level also?
Yes, sir.
What should be the above which one you will say is respiratory failure, or there are two types of failures now. One is hypoxic failure, other one is respiratory type 1 failure and type 2 failure. Okay, so COPD patients go into what type of failure? Type 2 or type 1?
COPD patient will most likely to go in type 1 failure, sir.
Type 1? Type 2 is ventilatory failure, isn't it? PCO2 goes up, PO2 comes down. Okay, that is common, isn't it?
Yes.
Is it not? That's what happens. Now PCO2 goes up, PO2 comes down. So that's when you have to sort of do something about, improving the respiratory efforts, and then improve the gases and other things now. Okay, all right.
Okay, so now let's come to, I think,
Sir,
let's come to.
excuse me, madam, we are just around 1 hour. So that can go to some preparation and scenarios.
Yeah. That's what I was saying, that we'll go to the pre-op preparation of the patient.
Yes, sir. Thank you.
Okay, Payal. So how will you prepare a patient of COPD coming for surgery? 1, 2, 3, 4, 5.
Madam, yes, I would first of all I would like the patient to continue his own medication which he is taking. Then advise the patient to give the nebulization to the patient prior to surgery. Then maintaining of the adequate hydration of the patient, and cessation of smoking.
Yeah. So that should be first, isn't it? Ask the patient to stop smoking. How does that help?
Madam, cessation, when patient is quitting the smoking, then the carboxyhemoglobin level, carbon monoxide level, and the nicotine level of the blood comes down, and it improves the mucociliary function of the patient, and it also improves the respiratory capacity of the patient.
So how long does it take for the carboxyhemoglobin levels to come down?
For madam, carboxyhemoglobin, it takes 48 to 72 hours to come down.
carboxyhemoglobin.
In madam, 12 to 24 hours, the carbon monoxide and nicotine reach to normal. In 24 to hours, the carboxyhemoglobin level will come to normal level.
Right.
In 1 to 2 weeks, the patient will improve the sputum production and mucociliary function. In 4 to 6 weeks, there will be improvement in PFTs, and from 6 to 8 weeks, there will be improvement in the PFTs and the ciliary function. And within 6 months, the patient will be same as the non-smoker. Risk will be same as non-smoker.
Okay. So you said you will optimize, you will ask the patient to stop smoking. You will dilate the airways with beta agonists. So the patient is on long-acting beta agonists. You will add short-acting agonists to the pre-existing one, so that all his bronchospasm gets sorted out. What else will you do?
Maintaining adequate hydration.
Adequate hydration. What else? Why is it important, hydration?
Because maintaining adequate hydration improves the sputum production and maintains the sputum production.
Right. So what else will you do in the pre-op? You know, you have seen the patient in the PSC clinic. What else will you tell him to do?
I will advise him deep breathing exercises, incentive spirometry, and chest physiotherapy.
Right. Chest physiotherapy, very important. Why is it important to start that? Does it have an effect in the post-operative outcome?
Yes, madam. It improves the breathing capacity of the patient in post-operatively, and it also improves the vital capacity of the patient, and it improves the clearance of the mucus.
And most important, it trains the patient to do these exercises in the post-operative period. So because many a times when you ask the patient to do these exercises in the post-operative period, when he may be a little sedated, when he may be in pain, he will not understand. So if he knows from before how to do an incentive spirometry, he'll be able to do it much better post-op. In fact, that training is more important than the actual improvement in the outcomes. So because if you do pre-operative incentive spirometry and don't do post-operative incentive spirometry, there will be no improvement in the patient. Okay. So training the patient to do these deep breathing exercises for post-operative period is also important. So patient is coming for surgery, posted for surgery. What all bronchodilators, because that is going to be your very important in your management. So what will be your orders for the bronchodilators in this particular patient who is on Foracort inhaler twice a day?
Madam, I would like to nebulize with the inhaled short-acting beta-2 agonist, and along with the short-acting anti-muscarinic agents, if a patient is not improving with short-acting beta agonist, after that only I would like to add inhaled corticosteroids.
Okay, but patient is already taking steroids inhalers, so would you stop that?
No, madam, I will continue that.
You will continue that. And what will you give on the morning of surgery?
I will nebulize the patient with the short-acting beta agonist along with the short-acting anti-muscarinic.
He can take his normal long-acting beta agonist and long-acting anti-muscarinic agent in the morning, and then just before surgery in the pre-operative room, you can give him a dose of short-acting also. You know, that will keep him well bronchodilated when he comes to your theater. Okay. So continue with his long-acting inhalers, but add short-acting inhaler close to your time of induction, right?
Suppose the patient is on having a respiratory infection, would you like to take him at that stage, or would you like to wait for some time? And how long will you wait?
I would like to wait, sir, and at least for 4 to 6 weeks.
4 to 6 weeks. And smoking also stop for 2 months, huh?
Yes, sir.
Yeah, if it is an elective case, okay, he can be motivated to undergo an operation provided he meets all these criteria, all these conditions. Okay, so if he's a respiratory infection, he's going to be hyper irritable, he's going to develop respiratory events. Now, so definitely put him on appropriate antibiotics. And what are antibiotics you're going to put usually? Yeah, which antibiotic will be put?
Azithromycin.
Azithromycin. Usually it's a macrolide. Usually it's something like a erythromycin or azithromycin, etc. Okay, and sometimes the quinoline also they put, and also sometimes mucolytic agents also. If the sputum is thick, is not postural drainage, deep breathing exercises, incentive spirometry, hydration, antibiotics, bronchodilators, short acting, long acting, and then steroids. Okay, these are things which. Is there any place for oxygen therapy such patients?
Yes, sir. If patient is having PO2 less than 55, and if the patient has saturation below 88, then we put the patient on oxygen therapy. But we should take care that the FiO2 which we deliver, it is between 0.26 to 0.35, so that it does not hinder the hypoxic pulmonary vasoconstriction, which has already occurred in this patient.
Yeah, this you'll know from the severity of the problem. You'll assess from the spirometry. Okay, if and also upon his functional status, dyspnea and all these things. Okay, so if if a candidate who has got a low FeV1 ratio is there, about say around 30%, something like that, and then PO2 is around 55, definitely it helps. Even if you give a small dose, small flow, 2 or 3 tests per minute, and then it's called LTOT, long-term oxygen therapy, etc. It has to go on for some time like that. Reducing the this and improve his oxidation.
Including patients, right?
Yes, ma'am.
Sorry.
So,
Sir, can you hear me?
now I can hear you.
Any indication?
Yes. To particular function and left function, I would like to.
So,
do
what will be the
echocardiography.
signs that you look for on examination, which will make you want to do an echocardiography in these patients?
Madam, if patient is having orthopnea or PND, I would like to advise echo.
Yeah. Raised JVP? What are the signs of cor pulmonale?
raised.
In other words, I'm asking you the signs of cor pulmonale. Okay?
Yes, madam. Raised
So,
JVP.
Raised JVP, enlarged liver. So, whenever you, if you see any signs of cor pulmonale, you will ask for an echocardiogram. And on echo, you will look for, specifically want to see what the pulmonary artery pressures are like, if there's any evidence of pulmonary artery hypertension and any evidence of right ventricular failure. And also these patients are more prone to, if he's a smoker, then he's also prone to other cardiac problems. He's prone to coronary artery disease. Is yes or no?
Yes.
Because they have vasculopathy, these patients. So they may be having, there is an increased incidence of coronary artery disease in these patients, increased incidence of cerebrovascular disease in these patients. So your investigation, especially if he's going to come for a major surgery, should also be directed towards a cardiac evaluation. Okay? Clinically, if you can see that the patient can lie down flat and he can speak to you comfortably, that gives you a good indication of his cardiac function and that he is not in cor pulmonale. Okay, so preoperative preparation, anything else you want to add, Suren?
No, madam, everything looks fine,
I
madam.
think we have covered everything.
Yeah, it is detailed coverage.
Okay.
It took a long time for the optimization because it usually takes this much of quite long time to optimize a patient, especially a patient who has got lung signs like that. Then because I think the once properly optimized, then I think he will send through properly. Otherwise, he's going to be a lot of problems now. Okay, so now only you can go to the clinical aspect. That is how you're going to approach a patient coming for different types of surgeries. Suppose
So
a
this patient is for hernia repair, no? Inguinal hernia repair?
Yes, ma'am.
Okay, so what will be your anesthetic technique?
Madam, if patient is posted for open hernia repair, then I would like to go with central neuraxial blockade.
Okay. What will you give? What will you give? There are different types of central neuraxial blockade. No?
I would like to give spinal anesthesia, madam, with the adequate dermatomal level.
Up to what level would you like to block?
Madam, hernia can be done with level of T8, and I would like to take care that the level doesn't go above T6.
Okay. Why is that important?
Because, madam, many a times the COPD patients are dependent on the active expiration. So if the level goes above T6, the active expiration will be impaired, and even the patient can have respiratory difficulties because of the sympathetic block.
Okay, so number one, you said it's because if it goes too high, there will be sympathetic blockade. So therefore, the patient may have what? What will be the effect?
Parasympathetic overactivity will lead to the bronchoconstriction.
Will lead to bronchoconstriction. What else is the problem with a high block? One is sympathetic blockade. What else?
Hypotension.
Hypotension. How is hypotension bad for these patients?
Because, madam, it will decrease the blood flow to the lung, and it will impair the ventilation perfusion.
Good. What else? See, inability to cough or take a deep breath, inability to expire sufficiently. So these patients may be dependent on for expiration, your extraneous muscle, the abdominal muscles for expiration. If the patient, especially patients with emphysema, okay? So if you paralyze your abdominal muscles, their expiration may be further, may be impaired. Of course, coughing will also be impaired, but then you don't want the patient to be coughing while operating. So that's an advantage, but the disadvantage is that your expiration, your expiratory muscles will be also paralyzed. So those patients who are dependent on these abdominal muscles for aiding the expiration, those patients will have. What else is the disadvantage?
Battery low.
Patient may not be able to lie down for so long, you know. A patient of COPD may not be able to lie flat for so long. Yes? Yes,
Yes,
or no?
ma'am.
So that may be
Yes.
And then these patients may often be having a cough which may be very difficult to suppress. So you don't want a patient who's being operated for hernia to be coughing, you know, the surgeon is going to not like it at all. Okay, so those are the disadvantages of regional anesthesia. What are the advantages?
We don't have to intervene with the airway, so we will not stimulate the airway. So it is the main advantage of the regional anesthesia, and it will even provide post-operative analgesia.
Right. So supposing you have to give general anesthesia, supposing he is for laparoscopic hernia repair. What are the advantages of, you'll give general anesthesia or regional in that case?
Yes, madam. With laparoscopic, I would like to go for the general anesthesia.
What is the advantage of using general anesthesia over regional in laparoscopic?
Because, madam, we can give controlled ventilation, and we can maintain the inspiratory expiratory ratio, and even the if according to the ETCO2, we can even adjust the frequency.
What are the disadvantages of general anesthesia? So any technique, you should know what are the advantages, what are the disadvantages, so that you know what to look for, what problems to look for.
Disadvantages are, madam, we are handling the upper airway, so there are more chances of bronchospasm.
So what are you saying? You are saying that you will avoid intubation?
I'm sorry,
Yes,
I
sir.
missed it. There was a call. What did she say? Disadvantages of general anesthesia?
Madam, we are handling upper airway, so there are more chances of the airway irritation and spasm.
Okay. What else? So bronchospasm, number one. What else?
Then atelectasis,
Okay. What else?
pneumonia, post-operatively.
Yeah. Intraoperatively also pneumothorax, you had said it earlier.
Yes, ma'am. Tension pneumothorax.
Yes, you can have pneumothorax if you are, if the patient is having bulle, or if your spasm is, if you're using, if you're having to use high airway pressures for ventilation. And also the other problems, such as, what are the problems with general anesthesia? See, because these patients may have very little reserve, so even the mildest inadequate neuromuscular blockade, or even prolonged sedation with your inhaled anesthetics or with your narcotics, can tilt them towards hypercapnia and respiratory failure. Yes,
Yes,
depending,
ma'am.
of course, on the preoperative condition. So let's say if you have to give general anesthesia to this patient, how will you proceed?
I will pre-medicate this patient with the glycopyrrolate, 4 microgram per kg. Then I will give injection ondansetron 0.8 to 1 milligram per kg, and I will even give anxiolytics, benzodiazepine, midazolam 0.5 to 1 milligram per kg. And
When will you give them?
Sorry, ma'am.
When will you give this? When will you give all this stuff?
After patient is taken inside the OT and monitors are attached.
Inside the theater, after attaching the monitors. What is the disadvantage of using benzodiazepines, if any?
Yes, madam. If it is overdose, then it may lead to the respiratory depression.
More than that, depression, they really don't cause that much respiratory depression, yes. But the disadvantage with benzodiazepines is that they cause hypotonia. And hypotonia, especially in elderly patients, if he's an elderly patient, predispose them to hello, sorry. Hello, can you hear me?
Yeah, yes, ma'am. We could hear you.
Can you hear me?
Yeah, yes, ma'am.
Yes, ma'am.
Oh, sorry, there was a call coming in. So what was I saying?
Midazolam and benzodiazepine.
Yeah,
and
midazolam. Yeah, benzodiazepines. They can cause hypotonia, and then they can which has been shown to predispose the patients to post-operative respiratory obstruction, hypotonia, especially of the in the airway muscles, and in the benzodiazepines in the preoperatively, the night before, early morning, is acceptable, but just before surgery, so that the effect may persist into the post-operative period, I'm not a great fan of that. Not in elderly patients, and especially not in a patient where you may have also have, obstruction, airway obstruction post-op. Okay, Payal?
Yes, ma'am.
You should keep that in mind. And then why do you want to give ondansetron at induction?
Antiemetic, madam.
What time? What is the good time to? What should be the timing of your antiemetic?
Madam, ideally,
Current
Dexona should be,
acceptable.
ideally, madam, ondansetron should be given pre-extubation because it is short acting,
Yeah.
and Dexona should be given pre-induction so that it is a long acting.
Right. So it is better to give ondansetron about 10 to 15 minutes before reversal, and at induction there's no need to give ondansetron. You're not getting any advantage of that ondansetron. Yes?
Yes, ma'am.
Agreed?
Yes, agreed.
Okay. So you've given the pre-medication of glycopyrrolate to this patient, and but I'm taking away your midazolam. I'm not letting you give that. What else will you give before induction? Anything else?
No, madam.
Some narcotic, fentanyl or something?
No, madam. I would like to prefer giving tab block after induction for analgesia, intra-op and post-op analgesia.
Okay,
So
so you want to give a non-narcotic anesthesia. Yes?
Yes, ma'am.
You
Yes.
want to avoid narcotics completely. So then say that,
Yes.
which is perfectly justified, which is perfectly all right. So you can say that you would like to, your technique will be such that you will avoid narcotics in this patient. So, okay, so you will use, what is your induction agent?
I will use propofol as an induction agent, 2 mg per kg, and I will like to secure the airway with Prosil LMA after giving scoline 1.5 milligram per kg.
Why scoline?
For muscle relaxation, madam.
Are you planning to keep this patient on positive pressure ventilation or spontaneous respiration?
Positive pressure ventilation, madam.
Then in that case, why give scoline? It's a short acting agent, isn't it?
Yes.
So what is the advantage of using scoline in this patient? It's perfectly all right. Anything you do, you have to just justify it.
Yes, madam. Because if I'm not able to ventilate with the Prosil LMA, then I would like to intubate the patient, and I will get the best relaxation with scoline for intubation.
Okay, but he's not a difficult intubation. You said his Malampati classification was 1 or 2 or something.
Yes, ma'am.
So he's not, obviously not a difficult intubation, right?
Yes.
So then why use succinylcholine? Why not use your intermediate or long-acting relaxant for putting it in?
Madam, there can be unpredictable, difficult intubation.
So
There
is
can be.
that your routine management of intubating with succinylcholine
Yes, madam.
for all patients?
Yes, madam.
Okay, so just say that then. That this is our practice of using succinylcholine for placing the airway device, whether it is endotracheal tube or laryngeal mask airway. So you will put us Prosil LMA, okay, and then?
And then I will maintain patient with the sevoflurane inhalation along with the oxygen and vecuronium.
You will use vecuronium. What else can you use? Supposing you don't have vecuronium, what else can you use in this patient?
I can use, madam, many steroidal components, long-acting relaxants, and if at all I'm having cystic trachea, then I can even use.
What are the other steroidal muscle relaxants?
Rocuronium.
Okay. What else? Anything else? Cisatracurium, you said, huh?
Cisatracurium is benzyl isoquinoline compound, madam, but it can be used.
Okay. So oxygen, sevoflurane, and cisatracurium or icuronium. And then you will proceed. You will not use nitrous oxide. Will you use nitrous oxide? You will be giving 100% oxygen to this patient?
No, madam, we should not give 100% oxygen, but in our institute, air is not available. And nitrous oxide, I would like to avoid because
So you say that you will give 100% oxygen because air is not available. You're not going to be working forever in an institution which has no air available, no? So if you don't want to give nitrous oxide, say you don't want to give nitrous oxide and you will give air oxygen. But don't say you will give 100% oxygen just because I don't have it available. Yes?
Yes, madam.
Okay.
Yes.
So what will be your this thing? So what are you, once again, what are you going to use for maintenance?
Sevoflurane, long-acting muscle relaxant, oxygen with air.
Why not nitrous oxide?
Because, madam, if at all there is presence of bulla, then it can lead to the rupture of bulla.
Supposing there is no bulla, you've looked for it in your chest X-ray. He doesn't have hyperinflated lungs. So then?
Then nitrous oxide can be used.
So then you can use nitrous oxide. Okay. What else? Something you were saying, no, earlier. Just say it now. Because now is the time you will do it, no? Or have you already done the block?
No, madam, I will like to give the tap block.
Yeah, so say that, no? Because otherwise you are going to give the give anesthesia without any analgesia component. So how will you do the tap block?
Madam, in our institute, we give with blind tap block. I will like to give it in the mid-axillary line between the...
Never say blind. Don't say blind. Just say landmark guided block. Okay? Nothing is blind. You're not just going and poking into anything. Isn't it? You're being guided by something. Or a loss of resistance block or a landmark guided block. Something. Don't say blind. Okay? Blind is only an epidural, or even epidural is not blind. Right?
Yes, ma'am.
Okay.
So I would like to give landmark guided tap block between the costal margin and the highest point of the iliac crest in the mid-axillary line. I will take the midpoint, and with the help of the 23 cord spinal needle, I will fill the two pop-off, one of the external oblique fascia and one of the internal oblique. Then I would like to give 10 ml volume on each side with
this is a bilateral hernia?
No, madam, only unilateral. So right-sided I would like to give.
Okay. So intraoperatively this patient develops suddenly, you have got the patient on IPPV, airway pressures go up. So what is your ventilatory mode? Sorry, before I come to that, what is the what will be your ventilatory settings for this patient?
I would like to give the tidal volume to 6 to 8 ml per kg, then respiratory rate to 10 to 12 per minute, and I ratio to be kept 1:3 to 1:4 to prevent the air trapping and giving adequate time for expiration. Okay.
So how will you know that your ventilatory strategy is working?
Madam,
you're doing everything right. You know, what will give you an indication that my ventilation is okay?
Madam, from capnograph and the ventilatory counts.
So what will you see on the what will you look for in the capnograph?
Madam, capnograph, if at all there is air trapping, then the capnograph will not return to the baseline before the next inspiration has started, and the phase 3 will remain upsloping, there will be loss of plateau.
Right. So if that happens, what will you do?
I would like to add PEEP to compensate the intrinsic PEEP which is generated.
What else? This can, you will also look for for a reason why this is happening, no? What can you
Yes,
do
madam.
that this is happening? What could be the causes of this kind of catastrophe?
Yes, madam. It can be due to the extrinsic kinking of the endotracheal tube, or there can be blockage of the tube because of the mucus secretion or blood. There can be bronchoconstriction. There can be development of tension pneumothorax.
Right. Oh, and you're using a laryngeal mask, so even the laryngeal mask may be displaced, you know?
Yes.
So look for the position of your laryngeal mask. If there is any leak from the laryngeal mask, if your ventilatory pressures have gone up, that will give you an indication. So you rule out the extraneous causes and then auscultate and the chest and look for bronchospasm. So if supposing everything is okay, there is no kinking, there is your LMA is in place, there are no secretions, and what is the other one of the causes that you may have?
Bronchospasm.
So supposing this was an endotracheal tube and not an LMA, what could be the cause?
Endobronchial intubation.
Yeah.
Endobronchial intubation.
Yes. One of the very common causes is that your tube is too much inside, right? Okay. So you found that the patient is having intraoperative bronchospasm. You've ruled out all other causes. There is equal air entry, but there is a bilateral wheeze. What will you do?
I will deepen the plane of I would like to deepen the plane of anesthesia. I will give 100% oxygenation. Then I will like to give nebulization or shifting beta agonist by MDI 4 to 6 puffs. And even if it is not relieved, then I would like to give the intravenous corticosteroids.
Anything else you can give? IV? IV lignocaine sometimes works, especially when you're when it is an instrumentation of the airway which is causing the problems. So many a times we use that in very susceptible cases, before induction also. You're putting an LMA, so therefore I didn't ask you, but if you're intubating, then an IV lignocaine is also helpful in preventing or suppressing the airway reactivity. And deepen the anesthesia with what?
By increasing the concentration of MAC value of the inhalation agent, and by giving top up of the IV propofol.
What inhalational agent were you using in this patient?
Sevoflurane.
Supposing the patient is still having spasm, you've given, what will you look for, before you give propofol?
Blood pressure.
Yes. So if the blood pressure is low, supposing the blood pressure is on the lower side, you've already increased the sevoflurane also, and the blood pressure is on the lower side. Then what will you do? Will you give propofol? Would you like to give propofol?
Then I would like to avoid propofol. Nebulization with adrenaline can also be done.
Yes.
It is also one of.
Yes. You can do nebulization, and if it is extremely severe, you can even give diluted. You can give diluted adrenaline IV also. You can dilute it and give very, very very small doses. Titrate the dose. That really works if nothing else works. Final this thing. Okay. But the other thing you can use to deepen the anesthesia is ketamine. If you can't give propofol, if the blood pressure is low, then you can use ketamine. Ketamine is a very strong bronchodilator. Okay, and it takes care of analgesia as well, which may be the cause that your patient is having bronchospasm, you know, because your analgesia was not adequate or your block was not very effective. So the patient reacted and had a bronchospasm, isn't it? It could be. That's why we say that you deepen the anesthesia. The other drug which you can use is theophylline. I mean,
Yes,
if an
ma'am.
steroid and yeah, aminophylline, but you know, really it's controversial, and if the patient is hypoxic, then or anyway and hypercapnic, then you may have problems like the patients can have arrhythmias in these patients. Okay, so post-operatively, so the surgery is over. Now you have to get him out. So what will you do? 15 minutes before you have given ondansetron.
Yes, madam. I will give ondansetron 10 to 15 minutes prior, and I will repeat glycopyrrolate at the time of reversal. And with the neostigmine, I would like to reverse this patient. Dose is 0.05 mg per kg, and I would prefer the smooth extubation.
Mm-hmm. How will you do that? Smooth extubation?
After patient has achieved adequate respiration, I would like to suction, and then I will extubate the patient.
Is suctioning the patient?
And I can
put an LMA, no? How will you? You've got a laryngeal mask over the LMA.
I can even give lignocaine IV before prior to extubation.
Yes, you can. Yes, you can. Okay, so you've got the patient ventilating normally, and patient is breathing adequately. Patient is breathing, but patient is not waking up. Patient is very drowsy. You've cut off sevoflurane. It's been a while before you gave propofol or ketamine or something, but patient is very drowsy. What will you look for? What is your worry?
It is CO2 level, madam.
Yeah. So what will you do? How will you know whether the patient is retaining carbon dioxide or not?
Madam, by the from the capnograph, it is CO2 level I can make out. Then I will even check for the subcutaneous emphysema.
Okay. Will the end-tidal CO2 give you a correct estimation of the PaCO2 every time? Especially in this patient?
No, ma'am.
So if you want the end-tidal CO2 to give you a correct estimation of the PaCO2, what else will you make sure that the patient has? That the patient has adequate tidal volume, isn't it?
Yes, ma'am.
So if the patient has adequate tidal volume, then only your EtCO2 maybe, and your blood pressure is normal, only then your EtCO2 is reliable. So you should do a blood gas analysis if the patient is not waking up and look for the PaCO2, right?
Yes.
Okay. So the patient is sleepy but is breathing all right. How will you, what will you do? Let him breathe and get the CO2 out?
Yes, ma'am, I will wait.
The CO2 is high on, you've done an ABG and the PCO2 is high. What will you do? Will you remove the LMA and let him breathe and wait for him to just wake up on his own, and or what will you do?
No, madam, I will keep the LMA in situ, and I will like to give 100% oxygen with 10 centimeter of H2O CPAP. And
100% oxygen? Why do you want to give 100% oxygen? Patient is not hypoxic. Patient is, oxygenation is all right. Only if the patient is hypoxic will you give 100% oxygen, no? Yes?
Yes, ma'am.
Is 100% oxygen good for these patients?
No, madam.
Why not?
Because it abolishes the HPV response. Hypoxic pulmonary vasoconstriction is abolished
So
by
maybe
giving 100% oxygen.
maybe your PaCO2 is too high. That's why he's not breathing properly and he's retaining CO2. So don't give him 100% oxygen. Okay? And perhaps put him on pressure support or supported ventilation for some time till the CO2 is washed out and the patient wakes up. So what are the other things that you will rule out? So inadequate reversal is one thing that you will rule out, that may be contributing to the hypoventilation and CO2 retention, isn't it? What else can be the cause? You have not used narcotic, but if you have used narcotic, then that may be a cause for hypoventilation in these patients. So make sure that the patient is, check for the pupils, see that they are not constricted too much. Does the patient need a reversal of fentanyl or morphine or pethidine or tramadol or whatever you have used? Can that be a cause for his sleepiness and hypoventilation? So neuromuscular blockade, narcotic, and inhalational agents, make sure that patient, all those are out of the patient's system, right? Okay? And
Yes,
then
ma'am.
you put the patient on pressure support ventilation for some time. And once the CO2 comes down, the patient will obviously wake up. So once the patient wakes up, you will, you have removed the LMA. What should you be, what is something that you will make sure in the post-operative that it doesn't happen again in the post-operative period? Do you want to do something? This particular patient who is prone to, say, CO2 retention, his pre-op CO2 was, ABG was also around 45, 48. Little bit of whatever anesthesia and has made him worse. So what will prevent the CO2 from going up post-operatively? You can give them non-invasive ventilation for some time in the post-operative period till he is fully awake. Yes, Payal?
Madam.
I think Payal is tired. Suren?
No, madam. I had network issue in between, madam.
Okay.
She's through very well, madam, till now.
Yeah, she's done very well. She sat through all this marathon session. That itself is great. So post-operatively, you have to make sure that you, if the patient doesn't require non-invasive ventilation or a BiPAP or a CPAP for some time before you shift them out of the recovery room. Okay?
Yes, ma'am.
What else? Have I missed out something, Suren?
What about emergency surgery, ma'am? Any COPD coming for? This is with a planned surgery that we have time to prepare, but in an emergency surgery, you just 1 or 2 minutes, we just finish it off.
Yeah.
Anything you want to add up, Dr. Payal?
Yes, sir. If the patient comes for emergency laparotomy, I suppose, then I would like to undergo the patient with a thoracic epidural instead of giving GA to the patient.
Okay.
Only epidural?
Sorry, sir.
Patient coming with intestinal obstruction, okay, or a bleeding inside, then how will you do? You have to give GA only. Then
If the patient is bleeding and if the patient's vital is not stable, if patient has hypotension, tachycardia, then I would prefer GA in place of epidural.
okay, how will you go about it? Induction, just give a work plan. Your plan anesthesia.
I will nebulize the patient outside the operating room, sir, with short-acting beta-2 agonist along with the short-acting antimuscarinic drugs. Then I will take the patient inside the OT, attach the monitors, then pre-medicate the patient, and I will like to induce the patient with ketamine and scopolamine, and along with giving lignocaine 1.5 mg per kg previous to 10 to 15 minutes previous to intubation. Then I would like to intubate the patient and keep the patient on IPPV mode of ventilation.
10 to 15 minutes? You said 10 to 15 minutes. No. Before.
Nebulization.
Before induction. Before induction.
Nebulization, no?
No, lignocaine. Yes. When will you give? 1.5 mg per kg lignocaine. When will you give?
Prior to induction, madam.
Yeah, prior to induction, not 10-15 minutes before.
Yes, ma'am.
Okay.
Prior to induction.
Go ahead.
Then I will intubate the patient with the endotracheal tube, and I will check the bilateral air entry, and I will put the patient on the IPPV mode of ventilation with the tidal volume 6 to 8 kg, frequency to 12 per minute, and I ratio I will adjust to 1:3 to 1:4, and I will maintain the patient with the sevoflurane and long-acting muscle relaxant along with the O2 and air. And one thing which I forgot prior to induction, that is analgesic. I would also like to give fentanyl 1 microgram per kg as an analgesic.
What is the dose of fentanyl?
Madam, I would like to use in COPD patient as 1 microgram per kg.
Okay, you want to use a lesser dose.
Yes, madam.
Okay. Post-operatively, this patient, what are the important things?
Post-operative, madam, main concern will be post-operative analgesia. If I have coagulation profile done and if I have the investigations, then in patients with laparotomy also I would like to give tap block for post-operative analgesia.
NSAIDs?
No, madam.
Multimodal analgesia? Multimodal analgesia?
Yes, madam. Multimodal analgesia can be used, but NSAIDs should be avoided.
Why?
Because, madam, it can lead to histamine release and it can lead to bronchoconstriction.
What are the patients who will have? Do all patients of COPD have problems with NSAIDs?
No, madam, not all.
It's only the asthmatics basically. So if you take the history properly and make sure that the patient is not sensitive to, doesn't precipitate bronchospasm with, if required, you can use, you may not use it as the first line, but if the patient is having pain in the post-operative period and he doesn't give any history of sensitivity to ibuprofen or aspirin, you can use the NSAIDs, but you can always use paracetamol IV, isn't it?
Yes.
So you should use a multimodal. So when you're talking about analgesia, just say that I will use a multimodal analgesia. I'll give a block. I'll use, even with a block, you must add some other things, So you say you'll give a block, you will use paracetamol, and if the patient doesn't get relief, still complains of pain, then you have to give narcotic also.
Yes, ma'am.
And can you use neuraxial opioids in these patients? You're put in an
yes.
What will you use with epidural post-operative pain?
I can use, madam, fentanyl for the post-operative pain relief with this patient.
How much fentanyl? Can you use morphine?
No, madam, morphine should be avoided.
Which is a better agent for use post-operative pain? Which is a better agent? How much fentanyl will you use?
10 to 15 microgram.
Per hour? Or what?
Yes. No, madam. 10 to 15 microgram per hour.
Okay. only fentanyl, or you want to combine it with some local anesthetic?
Local anesthetic, madam. Dropivaki 0.2%.
Okay. You didn't talk about positioning, like whenever you talk about post-op, no? So the first thing you say is you will nurse the patient in the propped up position. So these patients are best nursed in the propped up position, although that's true for all patients post-GA, but these patients in particular need to be propped up, okay? And then oxygen, CPAP if required, nasogastric tube. Should you be using a nasogastric tube in these patients or not? What is the current thought?
Madam, nasogastric tube, if I don't know the NBM status or patient, if at all patient is inadequate NBM, then I can put the nasogastric tube, aspirate and then take out, because the current concept shows that presence of nasogastric tube impairs or weakens the cardioesophageal junction and it can lead to the aspiration. So by aspirating the stomach content,
surgery, patient is for emergency surgery, no? So supposing it's a peritonitis or something where you're expecting bowel this thing. Otherwise, as far as possible, if the surgical condition doesn't require it, you would like to avoid having a nasogastric tube. And the other thing, anything else? You will nebulize the patient?
yes, madam.
So you will nebulize the patient and you will continue the nebulization in the postoperative period. And one thing which we forgot for intra in these patients particularly is DVT prophylaxis. It's important, isn't it?
Yes, madam.
Why is it important?
To prevent postoperative chance of deep vein thrombosis.
These patients are more prone to deep vein thrombosis, isn't it? Why?
Because of the atherosclerosis.
Atherosclerosis happens in veins. Fine. No, that's not the reason. The reason is because they are polycythemic and they have very viscous blood. So they have a sluggish circulation and they are more prone to, they are hypercoagulable. They usually have hypercoagulability. So therefore they are more prone to DVT. So they should be, they should have a DVT prophylaxis. So how do you do DVT prophylaxis?
Madam, using the compression strings, intermittent calf pump.
So intra-op, you will use compression stockings and calf pump. And post-operatively, will you do anything else?
Yes, madam. Physiotherapy, physiotherapy or exercise.
Physiotherapy, early ambulation. So you make sure that the patient has got good pain relief so that you can ambulate the patient quickly. Then low molecular weight heparin. Will you give
Yes,
some?
ma'am.
Will you give some low molecular weight heparin to these patients? You should. Okay. Okay. No, not
Yes,
happy.
madam.
Don't want to give.
Yes. Yes,
So
I would
what
like
will be?
to.
So what will be the dose and when will you give the what time? How do you time it? When will you give it? These are practical questions I'm asking you. Because you will
Yes,
be
madam.
writing the notes in the post-operative orders. So you have to write all this.
Madam, enoxaparin 0.6 milligrams subcutaneously. It is given OD for prophylaxis.
For prophylaxis, 0.6 is a little high dose, especially in the post-operative period. They can get bleeding and hematoma and things. So I think our patients will generally give about 40 milligrams. So I would give a little lesser dose. 0.6 will be slightly on the higher side, right? For prophylaxis, unless the patient has got, is a known documented DVT or something, then the management becomes different. Suren, take over.
Yes, ma'am. I think it's a very comprehensive review about on COPD itself. And I think Payal has excelled in her presentation and in discussion also. And she has, I think with her discussion, preparation which she had taken for the last few days, maybe more than 10 days, she has prepared. Payal, you have done very well. It should be a big motivation because you have come in front of two big stalwarts in field of anesthesia, and it should boost your courage and confidence to face any examiner. Okay, at least if you get a COPD, you should thod kar dene ka.
COPD to fold degi ab. है ना Payal?
Yes,
Kaman sir, or Hetal sir?
Yeah.
No, thank you. Yeah, I am here, ma'am. Good evening, ma'am.
Good evening.
Good evening, Raghavendra, sir.
Another marathon session. I think we'll have to do something about it in future. Suren, we'll have to cut it short. We'll have to time it properly because 2 hours is too much.
Yeah. No, once we get into it, I don't know. We don't have any control all the time because we keep.
Yeah.
And
then
candidates
from question to question.
Yeah,
and you want to complete the topic.
No, madam. The candidates also make it very tough because they keep answering. So
yeah, so you have to.
So,
your level has to be pushed up.
Thank you, Dr. Jinx.
Thank you, Payal, and thank you, Dr. Raghavendran.
But just can I say a few words?
Yes, sir.
Yes.
Okay, so the assessment part has to be quite exhaustive as far as the COPD preparation is concerned. Preparation has to be quite elaborate. You have to prepare them well and get them into proper shape. But as far as anesthesia is concerned, we have to make it as simple as possible. Make it very simple, and whenever possible, go for avoid GA and go for either neuraxials or go for nerve block techniques. Upper limb means you can always do with nerve blocks, and try to avoid supraclavicular or interscalene. Go for intraclavicular or axillary blocks, or even a distal nerve blocks you can go. And preferable to use ultrasound if you got one. And like she said about this hernia repair and all, you can do with something like a peripheral nerve blocks also. We have infiltrations and iliacal nerve blocks and even some other electrospinal blocks all you can do, provided if the neuraxial blocks not possible. And we have to utilize more about central neuraxial blocks, even for laparotomies also. Now that we are all seeing and hearing more about the segmental spinals and epidurals and this and that, probably that will be the direction in which we'll be going in future for COPD patients. We can avoid all polypharmacy and then multiple drugs, and then the patient can come out in a better manner. That's what I feel. I think keep it simple, and neuraxial block, I think, should be placed much more in a COPD patients. Okay, thank you.
Thank you, sir. Sir, thank you. And sir, we are using segmental epidural for this type of emergency patients in our institute.
Fantastic.
So we are maintaining on that. And hernia, if single-sided hernia, we are giving the infiltration block. Even.
Yeah, that's what. Good, fantastic. Yeah. She did quite well, very well actually. She did. I think she prepared.
Thank
well.
you, sir.
Okay.
Thank you, sir.
Thank you.
So thank you, everybody. Thank you, especially Payal and Dr. Jigisha, who has been preparing this case for the last 2 weeks. And thank you, Hetal sir, for bringing everybody on this platform through this initiative. Thank you, Dr. Raghavendra sir and Dr. Punima ma'am, for taking this to the next level. Thank you.
Thank you very much.
Bye.
Bye. Good night.